My name is Larry Thiel. I'm Director of the Global Affairs Center here at the college, and thank you all very much for coming to participate in this, to listen to this event. This is a discussion, so they're going to talk, but we really want questions. We really want interaction with the audience if we can. Today's topic is the Ebola outbreak. I don't call it a crisis, but the Ebola outbreak. We will be discussing the nature of the disease, how to control it, and how it feels at a personal level to deal with people who have Ebola or may be conveying the disease. With us to discuss Ebola is a panel of faculty members, a student, and a member of the community with personal experience in West Africa, where the most recent outbreak of the disease has primarily taken place. The second from the left here is Judy Penn, who teaches biology here at Shoreline. Some of you may know her. And she's going to be talking about the science of the disease. To her right is Hermine Watkins, who thinks she retired from the nursing department faculty last year. And she's here to talk about the control of Ebola in hospitals, clinics, and the community. Did you pay her? Then, right behind me, I'm going to kneel down here, is Jim Jagwal. Am I pronouncing that correctly? Pretty damn close, huh? He was a Peace Corps volunteer in Liberia, and he left there in August of just this year of 2014. He's going to share with us some of his thoughts about his experience as it relates to the outbreak of Ebola in Liberia. And last but not least, all the way over to the right is Ugo Obianozi. Am I doing that pretty well? Okay. He's a Shoreline student, born and raised in Nigeria, and he's going to be talking about the local reaction to the outbreak of Ebola in his country of origin.
Hi, everybody. My job is to tell you a little bit about the science of Ebola, sort of the Cliff's Notes version of Ebola, the real quick one. The picture that we're about to see is going to show Ebola. It is a virus that is kind of unique in its appearance. It has kind of long and stringy. And this is a picture of a green monkey kidney cell in blue. And then all of the green stringy things that you see are the Ebola viruses that are emerging from that cell. And one thing that you can notice from this is that one virus, when it infects a single cell, can end up producing a lot of viruses as a result. So this disease, once the pathogen is in the body, can spread fairly quickly and cause quite a bit of damage fairly soon. Because it's a virus, it's really hard to treat because viruses tend to reproduce using our cellular machinery. And so it's very difficult for us to target something that a virus is using because that would be something in our cells. So it's a little more difficult to find cures or find treatments for Ebola for that reason. This virus doesn't live very long outside the host, probably about a few hours on a dry surface and maybe up to 2 days in body fluids. And then, Larry, let's do the next slide. This just shows the basic way that it's transmitted. It is body fluids, and then if you were to become infected, those body fluids would have to enter through an opening in your body. So it would have to be like your mouth or a break in the skin or something like that. Ebola, contrary to what you might have heard, is not airborne. It is not likely to become airborne. I recently read a study that had studied the genetic mutations in Ebola, and it hasn't really mutated nearly as much as they expected it to in the last several years. So it's not likely that it's going to become airborne at any point anytime soon. The transmission of Ebola is fairly low then compared with other diseases. And one thing that you'll notice, this is a little simulation. You can actually go to the Washington Post website and find this simulation. And you can kind of run it to see how many people would be infected by one person. And I stopped it, I froze it at 30 days, which is about a month. And you can see that Ebola, up in the upper corner there, that person only infected 7 people. Although it was pretty lethal, 3 of the 7 died. But if you compare that with influenza or measles or chickenpox, that same one person could infect 100 people in that 30-day period. So it's a lot easier to spread some of those diseases among the population. So you can imagine, if you look at those squares on the measles up there, if each of those people spread again to that many people, you can see how the epidemic would spread very quickly. Once it enters the body, it tends to go into the lymphatic tissue and into the liver, the spleen, and the biggest problem that Ebola causes is it causes what's called a cytokine storm. And that even sounds kind of scary. Cytokines are molecules that our immune system cells use to communicate with each other. And when Ebola infects, it tends to cause a massive release of these cytokines, and they in turn will trigger massive inflammation in the body. And the biggest effect of this is that it causes the capillaries in your bloodstream to become very leaky, and they lose fluid, and as a result, it's much more difficult to get nutrients to the organs. And it's also an additional problem is the fact that Ebola in many cases will cause clotting of the blood. And when it blocks blood vessels, when a clot blocks a blood vessel, again, you're not going to get nutrients to the organs. So typically the cause of death from Ebola is due to organ failure. In a few cases it may be due to something like a stroke where a clot will, if it lands in the right place, it could be also cause of death. But mostly it's organ failure due to lack of nutrients. So the next thing, the last thing I want to talk about, just very, very briefly, I teach a class called Epidemics and Culture, and one of the things that I wanted to share with you today is a little bit about how epidemiologists work with this Ebola outbreak. And so we often call them disease detectives because they work very much like detectives. They go out and they interview people, they look for clues, they eliminate suspects, and they really have to do a lot of communication in order to find out what's happening with this disease. So the first thing they'll do is they will talk to the people who have the disease, and then once they find out who they've been in contact with, then they will be able to trace any possible contact. And when I say contact, I mean close contact, like within a few feet, not like somebody across the room from me, okay? It's somebody who's been in fairly close contact with the patient. Then they need to track those people's movements and their contacts. And go ahead and do one more. In fact, do both of the next two. And so once they begin tracing, they'll monitor for signs and symptoms, and then also if somebody does become infected, they'll put them into a treatment area. But finally, last one, you can see from the very last slide, whoops, one more, Larry. Forgot I had that one in the middle. You can see sort of the network of contacts that can happen with just one person being sick, and you can imagine how this would happen if you had a very dense population, which is what happened in West Africa this time with this particular epidemic. The earlier outbreaks of Ebola were much smaller and contained because they happened in more remote areas where people weren't very densely populated. And so this one's different for that reason, because they were in dense populated areas. And with that, I'm going to let Hermine talk a little bit about the health professions and their perspective.
Okay.
Is it up there or just turn it off?
Turn it off. I have nothing to show. Okay, so I am Hermine, and I am a nurse, and I teach nursing here at school, have been for 30 years in our nursing program. So from the nursing perspectives, first of all, we nurses are highly trained when it comes to infectious disease and controlling infectious disease. Now, as you probably remember, early on when our patient in Texas was first diagnosed, there were 2 nurses who became ill. Partly what happened there, and I don't have any of the inside story, this is just my thinking as a nurse of what's been going on and seeing historically what's been happening with the CDC and all the protocol changes. The personal protective equipment that was available, I suspect, at the time when our first client was admitted, wasn't to the degree that it is now. And there have been a lot of changes that have occurred. And the complexity of it today is is a completely different world. It's like the man on the moon versus what we do on the floor, what we normally did. So as a nurse, when I was working infectious diseases, and I did infectious disease clinical research at the U for 10 years before taking this position here and teaching nursing, we all learn how to don, and donning means putting on personal equipment in order to keep ourselves safe, but not just ourselves, but also our patients who we're taking care of. That technology was not, that we had in place, was not protective when it came to Ebola. We were not using waterproof or fluid-proof gowns, and we were not using full masks at first. So now the training and the protective equipment that is used, first of all, it takes extensive practice and a team of nurses with a monitor who's present to ensure proper technique by putting on all the equipment. There is air pressure that's on. There is there's no ventilation. It's pretty tough to be in, from what I've been reading and looking at videos, what these nurses and healthcare professionals live through in being fully protected in this gear. But this gear now that is available and now that is being used and that they're training the nurses for and healthcare providers for is truly protective versus what was used in the very, very beginning. Okay, so it's a different story now because the healthcare system quickly learned what was not working. So I suspect that those two nurses who became ill did not have that high technology that is currently being used. Okay? So a nurse or a healthcare provider, physician, or whomever who is donning all this equipment has to be really well hydrated before they even put on all of these layers, and it's a number of layers, the minimum of 2 sets of gloves, often 3 sets of gloves. Everything has to be very well covered. Everything is completely contained so that there is no exposure at all, and there's layer after layer, both with gowning as well as hoods and so forth. You've probably seen the pictures, and she had a picture, the first picture you saw someone in full gear. So a nurse or a healthcare provider can only work for not terribly long in that kind of gear before they need to be relieved and someone else has to do this. In order to take this protective gear off, there has to be someone who helps this person. This nurse or this physician cannot do it by him or herself because it is so profoundly difficult in order to not contaminate oneself while doffing off all of this equipment. And then there is a monitor who monitors every single move. So the process of putting on and taking off is a long process. It's not a few minutes. And so this, again, is to protect so that there is no contamination of the persons who are caring for the clients, and there is no contamination in the room. Everything has to be processed very, very carefully with very specific ruling, and the training is extensive. Let's see, what else could I say? Do any of my nurse colleagues have suggestions what I need to address? Okay. Yes, please.
I was just going to add that I just read this morning that that was going on.
And that is interesting. I remember. Pardon?
Can you paraphrase what you talked
Okay, so tell me if I'm correct, Anna, in what you were saying, that there are some nurses who are picketing an institution because they wanted better equipment available to them and better training. And that's absolutely critical because not all of the institutions have the equipment, let alone yet the proper training. It's very few institutions who are at this moment completely ready for this. I actually commend the nurses for doing that. I'm somebody who's likes to be outspoken and say, let's get up to snuff about this. I remember back in 1981 when our HIV patients were first coming, and how we weren't adequately educated and prepared about some of the transmission at that time, and it was very confusing. And the thing that we nurses have to do is lots and lots of education, because if we understand what is and what is not, then we can help decrease the fears in the community. And I think it was very interesting to note that the family members of this man in Texas did not get ill. Did you all know that? The family members did not become ill. And that speaks to how actually how it is not as easily spread as people fear. And when Judy was talking about airborne, and what airborne means, when I am speaking, if I, for example, had tuberculosis or measles, as I'm speaking, viruses are going out there. And even though I may sit here for a few minutes, all my viruses are still in the air, and you breathing it in will then come down with measles or tuberculosis, depending on your immune system. Okay, it's not an absolute. Which is very different than how Ebola is passed. It's completely different, okay? And I know there's tremendous hysteria out there, which concerns me, because there are lots of decisions that are being made that I believe are inappropriate due to hysteria. Okay.
Okay.
It's your turn.
Oh boy. So my name is Hugo, and I'm a student here at Shoreline, and I was born and raised in Nigeria. And then for the 2 years before I came to America, I lived in the biggest city in the whole of Africa, Lagos. And then when I heard about Ebola hitting Nigeria on CNN, my first thought was like, oh my God, everybody's gonna die. Because if you know anything about Lagos, it is so condensed. Like there is, I don't know how to explain it, but it's like 21 million people living in a little dense population. So if someone has it over there, it's a pretty good chance a lot of people are going to get it. So, but I recently found out that the reason, because Nigeria was recently proclaimed that they were now Ebola free, and I was trying to think about why that happened, because it was very unlikely that was going to happen. So I found out that the man that came from Liberia that had the disease in the first place fell sick at the airport, and that's where it was detected first. And then from then, they took him to a hospital thinking he had the malaria, which is a very common symptom that he had. So because of that the guy didn't actually go into the city itself was the main reason that the virus was contained, because they took him to the to the hospital, and then after 3 days they found out that it wasn't malaria that he had. They tested him for Ebola and found out that he had Ebola. And then from then, the Nigerian, like Judy was saying, the epidemiology people, they started doing the investigative work and finding out who he had contact with, and then tracking their contacts. And then they were very, very good in doing that to get all the contacts that everybody has made, and that's primarily why it was over. Because in Liberia, as I understood, was that they didn't know the virus was there till like 2 weeks after it has exposed, and then by then, a lot of people had been infected. And even if that happened in Nigeria, if a lot of people were infected, there was nothing you could really do, because it was very hard to track or find people that had the disease or admit that they had it and stuff like that. And then where I'm from, I actually think that the disease might have, it might not be, like she said, it wasn't easily transmitted. And where I'm from, if you were sick and the disease was communicable, people stayed away from you, and like you went inside and stayed by yourself, because you don't want to be outside, because no one wants to be with you outside, because it's hard to deal with the disease and the expense and everything. Like it would be very hard to get someone that was sick to contact disease to other people. But that's pretty much what I can say. That it was a lucky thing that the man did not enter the city. It was actually stuck in the airport, and that was the main reason it was contained.
Okay, on to me. We'll get to your question later. All right, so I worked as a volunteer Peace Corps teacher in a community in Liberia called Harbel. Harbel is one of the towns that's located inside a Firestone rubber tree plantation. Has about 40,000 people spread out in small communities with a couple of larger towns. And so the Firestone Company pretty much operates the entire plantation according to their set rules. Harbel is a little bit different from much of Liberia in that it has some services. Much of Liberia does not because of the recent civil wars. So, for example, it does have some health clinics that are fairly well staffed and a hospital that had several well-trained doctors. And let me just call it the plantation, had a Firestone radio station that operated 24 hours a day. So it was a way that people on the plantation were informed about events and activities that were occurring. So that was the setting. So through the radio station, many of us learned sometime in February that Guinea had an Ebola outbreak. As a biology teacher, I immediately understood the implications, or sort of thought I understood the implications of that. And so then we also learned several weeks later that a case had turned up in Sierra Leone. And this was in, like I said, in February. So my thoughts around that time was, well, I wonder how long it will take before it gets to Liberia, because Liberia is surrounded by Sierra Leone and Guinea. So in March, we learned in the middle of March that there were cases in a town near the Guinea border where there's a lot of traffic between those two countries. So individuals that were infected were coming into Liberia for treatment. And then about a week later, we learned that there was a case that came in from Sierra Leone, and that particular person traveled to Harbel, where I was living. She lived about a mile from, or less than a mile from where I was living. When she arrived, she was sick. Her husband immediately realized that there was something really wrong. She was vomiting, and immediately took her to the clinic. The clinicians there, basically health workers, did have gloves. They did not have much else. They did have what we would call lab coats, and realized, because there had been information from the ministry, a little bit of information on the radio about this disease. The folks on the Firestone plantation were aware of the disease. The medical people were, not necessarily the rest of the community. And they immediately isolated this family in the house. The neighbors resented that. There were some pretty harsh words that went on, and the company realized, the doctors realized, we need to move this family. So they very quietly moved the family to an isolated house near the hospital where they were quarantined. It was the mother, the father, and a couple of children. She died, and the husband and one of the children had a fever but did not progress in the disease. I've never heard what the child really was sick from. The mother died. So during this time in March, we heard that there were some cases that people were dying. A few people had died, but then the story sort of near the end of March seemed to die down. Then suddenly in April, we learned that there were more cases. There were more imported cases coming in from Guinea and from Sierra Leone. And in this second wave, those folks moved around. And because they had family members or they were visiting friends, the disease gradually was spread that way throughout the country. More and more people were being exposed. And there were very few facilities that were able to track all these people. There was no tracking being done. People were just being exposed. And at this time, Firestone and the Ministry of Health in Monrovia, the capital, started publicizing on radio very actively every day, almost every hour, health announcements about what the disease was, how it could be spread, and what people should not be doing. But many of the health warnings were contrary to personal practices that people had, in addition to the fact that many people in the country, and I'm talking here as a volunteer and my observations as a microbiologist, many people in the country, because of the nature of the country, this is the fourth poorest country in the world, did not have the educational background to even understand what a virus was. I taught a class, and one of the subjects was viruses. So there were a few folks in a couple of classrooms in the country that did know a little bit about viruses, but generally people didn't know. So the ministry and the company on the plantation were putting out health statements very often, every day, many times, trying to inform people what to do or not to do, yet many people disbelieved it. There were many stories, which I heard from teachers, I heard from students, I heard when I was traveling in taxis. This is a government plot to make us afraid, so we respect them. It's a plot by Western drug companies to sell us drugs. It's witchcraft. There is no such thing as a virus. There were many stories of disbelief, and very few people found it acceptable to not shake hands with people, to keep, if you think somebody's sick, do not get close to them. People just would not accept this because customarily you need to shake hands with people, greet them in some way when you see them, friends or family. So publicity kept coming out. As a Peace Corps volunteer, we were getting pretty much weekly statements from the Peace Corps office about what the caseload was, what not to do. We were getting the same advice from the U.S. Embassy. NGOs in the country, NGO organizations were trying to inform their employees what and what not to do. And yet there was this general tone throughout April and May of disbelief among many employees. In May, we started hearing about people dying, people refusing to take their sick relatives to the hospital because if you do, they will die. There were stories about cannibalism being practiced in hospitals, or people's body parts were being sold. So there was a huge rumor mill. And it was very, very difficult to overcome that with getting people to really understand what the disease was about. So gradually, April, May, June, we were just hearing more and more stories about people dying, secret burials because families did not want to take their sick relatives to the hospital, the burial practices of needing to hold a dead body, to wash it before burial, that it was not going to be allowed for a family member to be cremated. People were horrified when they watched their family members being drenched in the chlorine, dead family members being drenched, healthcare workers coming and basically drenching the body in a chlorine bath, putting the body into a bag and then drenching the bag once more, dropping it into a grave and drenching the grave in chlorine, in a chlorine bath. People just could not accept that. It was a very, very difficult thing for many people to understand that it had to be done that way. In the meantime, more and more health workers were being exposed and dying. I know that about a month ago, up to 150 health workers in Liberia, including doctors, had died of the disease. So what was happening is there were more and more people being exposed, and a health ministry that was not able to take care or to have the proper equipment to take care of people who were sick. The health ministry spent its entire year's budget between April and June, and so there was very little equipment that was available for those people who were directly involved with the disease to use. That's being rectified with the aid that is coming into Liberia just now. But up until the time I left in August, we were hearing all kinds of stories about people dying and all kinds of stories about what this disease was about. Much of the problem in Liberia is the result of a very weak ministry in the sense of being very much underfunded because it's a poor country to start with. Secondly, very few people really understanding what the disease is about and having cultural practices that made it even more easy to get exposed to the disease by family members and friends who felt compelled to help a sick individual, sick relative or a sick friend. And that was the story with the man who came to Texas, where he was asked to help with a sick friend, help carry a sick friend into home the day before he left. He was assured that the person was not dying of Ebola, that they were sick with either cholera or malaria, which is what many people thought initially the disease was. And so he had been exposed and started showing symptoms when he arrived here. And as was stated, it is true that it's very difficult to spread if you're not directly touching any of the body fluids of the person. And as you notice, the family members of this person that came here did not get the disease because of the way probably they did not touch this man after he got sick. So basically my experience being an observer there was just, I was not afraid of the disease at all. It was, from my training, I understood how it could be spread, and I understood what could be done to avoid it. Many people in the country there did not have that experience initially, and many refused to listen to that advice on the radio initially. That's a lot different now. People understand. Many communities have organized to keep it under control. Harbel, after the initial case, has not had any more cases at all because of what that company did to inform its employees and how it took into control the very, very strict monitoring of everybody who was on the plantation. And so they've avoided any further contact or any further cases. All right.
Does anybody on the panel want to add anything before we open up the floor?
I would like to say one more thing. Yes, what Nigeria did was great. Senegal did the same thing, and I don't know if you recently, Mali had one case, and Mali followed the same practice immediately, getting that person into isolation, treating them with fluids so they could recover, and that's the most important thing is immediate care. Very early in the symptoms, and it can be controlled, and that's what we've learned here too. The initial problems in the hospital in Texas was people were not completely prepared. They were not properly gowned.
That's right.
They did not have quite the right equipment. Right. They weren't properly trained. But you know, it's a good alert for all of us. Is take us listen to your medical people and take their advice seriously. Don't listen to politicians.
Oh my goodness, that's good advice.
Please, when you hear a question, just repeat the question because we are recording. We don't have a Wi-Fi mic. So who would like to ask a question? Right here. So, if you would stand up and shout, that would be great.
So my concern is that a patient that's potentially exposed with Ebola could end up in any hospital in the country. And based on my experiences in hospitals and what I've heard from other healthcare workers, I don't feel like every hospital in the country is ready for that. And so what would you recommend as somebody that is in a hospital environment frequently in smaller hospitals that aren't Harborview?
Okay, so I heard you ask or say that your concern is at any time in any hospital that one might be exposed to an Ebola patient as a nurse or a healthcare provider. Is that's what you're saying, right? And the preparation.
I'm not talking about like every single department in the hospital, but still, every.
So the CDC has put out some really excellent, how do you call these in English? Yes, and yeah, but also schematics. So if a patient arrives, a nurse or a healthcare provider immediately has to ask very specific questions. If there is any symptomatology and or fever, okay, it's a very specific guide that's happened. If it's a yes, then one does this. If it's a no, then this. It's very clear and specific, and every institution, as my understanding, is implementing this, no matter whether it's an ER or ambulatory service or any hospital. So by clear adherence to understanding what this is, and I have copies of that in my thing, you can download it from the CDC, that immediately then would institute whatever is necessary, because if it's a yes, then this is done, and it's step 1, step 2, step 3, step 4, and then immediately the system is activated. Okay, so it is possible anywhere in the U.S., absolutely, but I think we have learned very quickly from Texas and from a couple of the other hospitals of what needs to be done at every single level in healthcare system. And I believe that's being instituted if it's not already instituted. Did that answer your question?
Kind of, just really more after, if the answer ends up being yes, they do have Ebola, are they ready to handle it?
Not all institutions are. So then there is medevac. People will be medevac to the appropriate institutions that have the best and the most up-to-date training as well as units in order to deal with that. Okay, so a person with Ebola would not be at Skagit Valley Hospital or any of those. It would immediately, the system is activated and the person is transported to where there are the properly trained people and equipment.
And we're lucky enough to have one of those facilities in our area. Harborview is one of those locations.
And you'll note if you were going to a hospital to see a doctor, one of the, right now in most, I think most institutions in this area, the first question is, have you been in West Africa within the last 21 days?
I worked in an ER last week, and they did ask every single question, every single patient with that list of questions.
Yeah.
They probably used a schematic that's, yeah, okay. Okay.
Question right here. So my question is, I think one of the scary parts about this disease is that the early symptoms mirror flu, they mirror like a ton of other diseases. So is there any way to distinguish between the earlier stages and other diseases like, say, the flu?
You want to answer that?
The very first stage looks a lot like malaria. It could be typhoid, which is very... Oh, okay. What are the early symptoms? Because they mimic others. The Ebola, the initial Ebola symptoms can mimic other diseases. So I know in West Africa, one of the reasons that it spread is that many people assume they first had malaria, because almost everyone says they have malaria, at least in Liberia, or typhoid, which is a kind of salmonella poisoning. So it's hard, but in that first day, often what usually happens when a person gets a fever is that if they're able to monitor their fever, it rises pretty quickly. It doesn't stay steady. It's a rising fever, so that's a clue. But it does take monitoring. In Liberia, there's very, very few people that had a thermometer. So in this country, if somebody's been in that area and then has a fever, that's the first thing. You watch them right away. And if they have a rising fever, you can be on alert immediately.
And in part, it's also dealt with by the healthcare providers by asking questions. Okay, have you been exposed to the flu? Anyone in your family or who you've been with have flu symptoms? And then also, where have you been? Have you traveled? So there are a number of questions and schematics that are used, and there's one from the CDC that's regarding flu versus Ebola. And so quickly that's activated and it is determined, okay? So with the flu, one is sick within a couple of days, have good high fever, whereas with Ebola, it takes at least a week or so from exposure, okay?
Yeah, I don't think anybody's mentioned this, but Ebola, in terms of infection or the time you get the illness, can be anywhere from 2 days to 21 days. Usually it's between 5 and 8 days.
My question is, if a person is infected with Ebola and they are cured, is there a chance, or are they immune, or is there a chance they will likely catch Ebola again, and how long?
Want me to? So the question is, if a person is infected with Ebola and recovers, are they immune? And what was the last
If they are cured, are they immune from then on, or is it possible?
For life. Yeah, are they immune for life? I don't think we know completely how long the immunity lasts, but there appears to be immunity at least for the short term, maybe a few years or so. But because the outbreaks up to this time have been so limited in number of people, and most people in those outbreaks died, it's been hard to gather data for that. But in this one, at least what I'm reading is they're saying, you know, it's hard to predict that it will be lifetime, but they think at least for a few years there's immunity. And they can detect antibodies in the blood that shows that.
Yeah, and to add to that, in Liberia, they have been, because there's so few healthcare workers, they have been using people who have recovered to help with people who are sick. And I don't know this for sure, but apparently none of those people have gotten sick again. So there's some assumption that there is immunity. How long it lasts, nobody knows. Yeah.
So my question is on U.S. policy. Right now, the Energize Africa Act is on the floor, waiting to be voted on. This got passed as the Electrify Africa Act. And I know that this pertains to global health because a lot of vaccines have to be refrigerated, so access to electricity in Africa can be hard and can really impact something like this. How does it impact Ebola? Is it the same? Do you have to refrigerate these vaccines? Is access to electricity kind of affecting the spread of Ebola in any ways?
I can probably take that one. So the question is, does limited access to electricity have an impact on treatment of Ebola or prevention? The unfortunate thing is we do not have a vaccine right now for Ebola. There are some that are being tested, I believe, in Africa right now, but they're just in the very early stages of testing. So at this moment, that's not, unfortunately, not an issue. The treatment methods also are so limited. Most of the treatment in West Africa is frankly what we call palliative care. It's really just taking care of the patient, making them comfortable, and providing them with nutrients, but not so much in terms of drugs. There are experimental drugs being used in this country. You've probably heard of ZMapp, and that one essentially is mimicking the antibodies that somebody would have and trying to capture the Ebola virus in the bloodstream. But I don't think that that's being used extensively in Africa right now because there just isn't enough of it.
Good questions?
Hi, I think it's incredibly important to discuss Ebola in a social justice context. More specifically, the racial politics that have contributed to this hysteria. It's perpetuated particular imagery of the continent of Africa. And I think this was exemplified through Thomas Duncan, the Liberian man who died in Texas, who went to the hospital and was turned away. This is a man from Africa, a black man in America. So if you can speak to some of those issues.
Okay, so a question about racial politics involved in this outbreak. I've seen two sides of it, I guess, in a way. In living in Liberia, there were people saying, as I implied, that it was a plot by drug companies, Western drug companies, also that it was a plot by, and let me just say, an unnamed foreign government that was trying to gain political influence in Liberia. Here, my first response when I heard about the outbreak in Texas was This man was turned away from the hospital because he didn't have insurance. He was just given an antibiotic to go home. And maybe because he was a foreigner and also somebody from Africa, a black man, that he might have been not treated correctly because of his race. As a Peace Corps volunteer, I have a fellow volunteer who just 2 weeks ago went to have treatment at a hospital, and the doctor refused to help her because she had been in Liberia and has been home from there since the beginning of August. But their Liberian folks did feel that they were not being treated as well as the white doctors, medical people who were being flown back to the United States and being helped, and that, hey, if they're going to get, the special treatment, why are we not getting it? That aura, that sort of sentiment was there. It wasn't expressed a lot, but it was there. I heard a little bit of that from some of my teaching colleagues, Liberian teaching colleagues. So it's there. I don't know exactly, how ingrained, let's say, it is, but I know it's there, that there is some issue about that. And I think in this country, people are realizing, hey, this disease gets anybody who gets in touch with it, and we need to deal with it as a population, not as a racial subgroup. Yeah.
Yeah, I would like to address that for a second. I've been in healthcare in some form, and the last 45 years as a professional, but since 1965. And racism in healthcare is alive and well. We know that. And it takes a lot of education and awareness in order to effect that change. Here, personally, in our nursing school, we teach, and it's a curriculum that I developed myself, healthcare through a social justice system, and trying to educate nurses to become self-aware of their own biases in order to hopefully that we can effect a change in this and make a huge difference. I know it's alive and well, and I know that if you have money, you get different treatment. If you don't have money, depending on one's color or where one comes from, or if you're a non-native speaker, I know these things. I've been around for quite a while, and I've seen it, and it's unfortunate. It is inexcusable. And it's going to take a lot of us to be open about it, to be specifically call it what it is. It's racist, and it's inequity, and we've got to make a personal commitment to effect that change. It's going to take us, as you well know, a whole lot longer than we wish. Yeah. Okay.